So let's move on to case two. Case two is an adult male who had prenatal genetic screening. And I bring this up in a pediatric setting because this, as we do start doing newborn screening more for Duchenne dystrophy, this kind of scenario may start coming up depending on the technology that's used. This adult has normal muscle strength and a normal serum CK level, and then had an in-frame duplication detected in dystrophin. And the question came up genetically, is the duplication in tandem? And this is a research study that was done in my lab. Nanopore sequencing is a technology that we are using pretty frequently in my lab. And we confirmed that this duplication was in fact in tandem, meaning that the two copies of this section of dystrophin were right next to each other, indicating that this is a benign variant. What this suggests is that as we start doing more asymptomatic screening, prenatal screening, newborn screening, and depending on when the genetic testing comes into play, we will likely be detecting more and more benign variants, and we'll have to be ready for how to interpret those. And this is just a diagram from a recent publication indicating how we determined that this duplication was in tandem. So current newborn screening methodology relies on a two-tier system. You take the dried blood spots from the newborn screen, you check the creatine kinase level, and then those who have significantly elevated levels then go on for genetic testing. So the individual in question would not have been detected on this current process of newborn screening, but if we contemplate a future when exome sequencing or genome sequencing is done on a routine basis in newborns, these types of variants will be picked up, and then we do have to figure out how will we interpret them, how do we figure out whether they're benign or not in a clinical setting. So let's move on to case three. You receive a call from your state's Department of Health. You're in your practice right now and in your clinic. A newborn that you accepted into your practice but have not seen yet is tested positive for SMA on newborn screening. So you are referring immediately to the nearest comprehensive neuromuscular clinic, and you also add this patient onto your schedule for the next day. It's important to remember physical examination may be normal or pretty close to normal in most cases. Some neonates do present with varying degrees of hypotonia and weakness, and others might have normal neurological examinations. For those of us who have seen these newborn screening results in our practices, sometimes they're accompanied by information about SMN2 copy number, and that's a similar gene that's on the same chromosome as SMN1, and SMN1 is the main driver of the disease status. But the second form of the gene, SMN2, can alleviate some of those manifestations. So it helps, knowing the copy number of SMN2 can help you determine prognosis, but it's not perfect, and it's not something we should rely on in isolation. So as a lot of us have seen in our practices, SMN1 deletions are the main type of genetic variant associated with SMA. And then the copy numbers of SMN2 vary due to recombination events, and it tends to be fairly unstable. Usually you just have two copies of every gene. In SMN2, this is an exception because the copy number can vary a fair bit. And the fewer copies one has in the setting of SMN1 deletion, the more severe the disease is likely to be. But the correlation is not precise due to a variety of other factors. So the patient in question turns out to have 4 copies of SMN2. So 4 is twice the number that you typically have. And so you'd think that this would be a relatively mild case, but that's not always true. So if you see this table from a paper from just last year, that SMA3, which is one of the milder forms of it, is most closely tied with having 4 copies. However, 4 or more copies. However, you do see a few instances of the more severe cases, SMA1 and SMA2. So that is a cautionary note. So in the clinic, this infant with spinal muscular atrophy was found to have mild signs of hypotonia. And the parents are presented with 3 FDA-approved options, and they're here on the table from a recent publication from us. And I mentioned this before, there's the nusinersen, which is intrathecal, the gene therapy in the middle, and then the risdiplam, which is the oral therapy on the right-hand side. So after some deliberation and discussion, the family decided they wanted to proceed with gene therapy. We did some preliminary lab work. Insurance approval, as some of us may have encountered seeing these patients in our clinic, can sometimes be a hurdle. The gene therapy is costly. It's $2.1 million. And so there is sometimes some questions, as you can imagine, from the insurance company about this. And so there's a lot of paperwork that needs to be submitted, including genetic test results, a lot of this preliminary laboratory work. So in this case, the insurance company denied the authorization due to the 4 copy numbers of SMN2. However, we really felt that the infant was at risk. The infant already seemed to be having some symptoms, which is a bit concerning. So after a little bit of back and forth, we received insurance approval and the infant received gene therapy at 4 months. So this is what happened after the infusion. So the ALT and AST were pretty normal in the pre-infusion stage. Remember, this is spinal muscular atrophy, so normally the ALT and AST are in normal limits. But you can see by 6 weeks, there is a really tremendous spike, and the GGT peaked at 1,345. So this was a delayed immune reaction that can be quite scary. And this is an illustration of why post-treatment monitoring is really, really important in gene therapy. You do not want to lose sight of these patients for quite a while after they receive it. So we had to, the standard protocol does involve steroids. We had to go up on the steroids. We had to admit this patient to the hospital and switch to IV for a little while. And subsequently, his LFTs normalized, and he's been doing quite well, and his motor development has been really excellent. So that it all ended well, and this illustrates how important the monitoring is.